Welcome, everyone. Thanks for joining us today. My name is Dr. Louise Ivers. I'm the faculty director here at the Harvard Global Health Institute. It's my pleasure to welcome you to HTHI's Global Health Research and Innovation Speaker Series. This is our monthly series hosted to showcase the latest advancements in global health research with the goal of fostering dialogue and elevating innovative solutions that advance health outcomes worldwide. We welcome you to continue to join us for timely discussions arising from the field every month. So before I introduce our speaker today, I have a couple of notes. The session is being recorded through Zoom, and the recording will be made available on the HTHI website and YouTube page in the coming days. We will have time at the end of the session for your questions. So if you have a question for Dr. Fawzi, please submit it through the Q&A feature at the bottom of your screen, and we'll do our best to get to that in that session of the event. And with that, please allow me to introduce our speaker. Professor Wafaie Fawzi is a physician and an epidemiologist focused on advancing global health research, education, and practice. He is professor of nutrition, epidemiology, and global health at the Harvard T.H. Chan School of Public Health. He established and continues to lead the Nutrition and Global Health Program, an interdepartmental initiative at Harvard, where over the past 25 years, he sought to strengthen the evidence base for advancing human health and development. Professor Fawzi is an elected member of the National Academy of Medicine. His research is focused on addressing global health issues in populations in Tanzania, Uganda, Sudan, India, and other countries. Dr. Fawzi's primary academic interests include the design and implementation of randomized control trials and observational studies of maternal, neonatal, and child health and infectious diseases with an emphasis on nutritional factors. He's the founder of the Africa Academy of Public Health, the ARISE network, which he'll speak about today, the Africa Research Implementation Science and Education Network, and CHAN, the China Harvard Africa Network. So with that, it's my honor to welcome Professor Fawzi and pass the floor to you. Thank you so much.
Great. Thank you so much, Louise. Great opportunity to be here with you today. The Global Health Institute brings us all across the university on all issues related to global health. And thanks so much for your leadership and for the opportunity to share some of our work today. It's all right, I will share my screen. Is it okay?
Yes, it looks great.
Okay, thanks so much again. So I'll cover today in the time we have in the next 25 minutes or so, some of our work on advancing global adolescent health and nutrition. Adolescence is a large segment of the population in most countries. In many settings in Africa, it's about a quarter of the population are 10 to 19 years of age. And if you expand that a little bit to include young people, sort of 70% of sub-Saharan Africa is under the age of 30. A sizable part of the population that typically has not received as much attention really in many of our global health programming. There is a lot of emphasis on maternal and child health, and there should be under 5, first 1,000 days, increasingly a lot on older individuals and NCDs, and there should be more, but the group 10 to 19 has not received as much attention. And it's a group that sort of affects sort of the future of these individuals, that age bracket. Many of the behaviors that have lifelong consequences start in adolescence, whether it's dietary preferences, physical activity, mental health, drug use, etc. So it's really important to invest more into this age period. What I'll try to cover is outlined here, a little bit of a background first before I go to a set of studies that we have carried out as a network, and then summarize with sort of key messages. If one looks at the group 10 to 19, there is a particular dire situation in sub-Saharan Africa, particularly. If you look across time on the x-axis, mortality rates among adolescents are almost twice as high in that region compared to the rest of the world. And if you think about it with respect to mortality or disability-adjusted life years, there are a number of causes that I'll highlight briefly. So if you examine 10 to 14 sort of early adolescents versus 15 to 19 among girls, you find that the top cause is iron deficiency anemia. And then there are other factors, lower respiratory infection, diarrheal diseases, certainly mental disorders start becoming important, particularly later on in adolescence. And if you examine that among male adolescents, a similar pattern with iron deficiency being really the top cause of days lost among young adolescents, with that being overtaken by road injuries and other sort of factors, violence, and self-harm, and mental health in older boys. So one of the efforts that we have tried to advance really as a network is to examine questions around adolescent health. ARISE is a network of 10 countries in sub-Saharan Africa, launched about 10 years ago, bringing together about 21 institutions in 10 countries. It's a little older slide, convened by us at the school and our partners at the Africa Academy, a partner organization in Tanzania. Our efforts really within ARISE has 3 pillars. We focus on cutting-edge research with particular interest around maternal and child health and adolescent health. And nutrition is one area that I'm interested in, but it is meant to be part of a kind of multi-sectoral, multi-domain emphasis on adolescent health. We advance capacity really in partnership with institutions in sub-Saharan Africa, and do that really in a model that is hopefully sustainable and in a true partnership model, where we seek to sort of work with our partners as a network, enabling South-to-South collaboration and learning from one another, where we are hopefully contributing, but we are also learning a lot in the process. Our efforts around adolescent health are sort of shaped by 3 different strands of research, really. And I'll take these in sequence to just highlight some of our current and recent findings. On systematic reviews, we have carried out a series of systematic reviews, and some of them are listed here. Some are ongoing and others have been published. But essentially, the effort is to take stock of the evidence as it stands in the field before we move on to additional research. So scoping reviews, systematic reviews, and meta-analysis when that is possible, looking at sort of interventions among adolescents in the school setting or in community settings, be it addressing undernutrition or double burden of malnutrition, and so on. And I'll highlight a couple of them. I'm happy, obviously, after the seminar, happy to follow up with any individual if there are interests in some elements that time may not allow to get into. But this is one systematic review that looked at the role of school feeding interventions. Now, these are sort of interventions that are provided to students in the context of schools, as the name implies. It takes a variety of forms. It might be a snack, it might be a midday meal, etc. A lot of heterogeneity in what is offered and the quality and quantity of what is offered. But a number of studies have been done, and in almost, well, I would say in most countries in sub-Saharan Africa, this is provided, but with varying levels of intervention and quality, at times with some complementary offerings of deworming or other interventions. So we looked at the evidence among all studies that have pursued that in controlled studies. In a second review, we looked at sort of holistically at other interventions beyond school feeding programs, interventions that provided nutrition counseling or wash interventions, water sanitation, and hygiene, or other approaches. And a variety of studies have been carried out, but overall, if one can summarize some of the key lessons from these various systematic reviews that we have carried out, that in essence, integrated approaches typically are better than single interventions. They are more effective. Even though there is limited really evidence overall, whatever we know so far points in that direction. School feeding programs are effective in some way, improving nutritional status, enhancing school attendance, and in some limited data, enhancing cognitive development. But much more needs to be done to examine their role and contributions. Nutrition education provides the ability to sort of choose to the extent that there is choice and there is affordability by school adolescents and their families. Targeted micronutrient supplementation addresses specific deficiencies such as iron or folic acid. But overall, really, a dire need for sort of a significant emphasis on monitoring and evaluation to be able to examine this variety of interventions much more completely. Lots of gaps in the evidence, which is, I guess, important for us to pursue. Many students who are interested to engage with this area of research. There is a lot of contributions that can be made. We need to know more about the long-term effects of these various interventions. We need to study not only the effectiveness, but cost effectiveness of these interventions, examining how they can be sustained, resource allocation, and engagement with policymakers to see that whatever we know out of certain studies is really scaled up beyond small pilot studies. And integrating across domains is important. So not only undernutrition, but thinking about the double burden of malnutrition is critical, engaging with other challenges, sexual reproductive health, mental health, drug use, other domains that affect adolescents would be important to examine holistically rather than single interventions at a time. And think about the unique needs of girls versus boys in some settings is also critical. So as we advanced in examining the evidence, in parallel, we have begun developing sort of observational cohorts to take stock of the state of adolescent health. What do we know? What do we not know? In order to be more prepared to engage with intervention programs and studies. So I'll speak briefly about some of our observational cohorts. We have carried a series of them. One study that started us off really is a community-based study in our various partner sites in Africa. They're typically, these are universities in each of the ARISE sites. We work with one or two or more universities in the country. And through them and with them engage with a demographic surveillance system that typically is a population of 100,000 or so under surveillance for various demographic births, deaths, migrations in and out, and so on. And utilize that platform to examine in a subset what is the state of adolescents in those communities. In a separate study, we looked at school-based adolescents, school being really a unique platform of an institution that provides access to large numbers of adolescents, increasingly over time. Primary school education is practically universal in most countries. Secondary education is on the rise, and so provides really a wonderful opportunity to engage with adolescents and other stakeholders. And increasingly moving from cross-sectional snapshot analysis to longitudinal analysis, longitudinal assessment that enables assessment of critical indicators over time. And as we try in all our efforts really engage with capacity building so that the data is collected and analyzed with support of junior investigators as they are rising and gaining skills, and publishing. So these are sort of special issues in 2 journals that have resulted from 2 of these studies. Most of the papers all the papers are led by colleagues in partnership with our faculty and their faculty in those settings. Some of the key findings are here. I'll just highlight a few. In most settings, this is our very first study among community-based adolescents. Regardless of the setting, there is continued presence of underweight, undernutrition among adolescents 10 to 19, stunting, as well as sort of undernutrition. But a rising tide of overweight and obesity, whether it is for females or males, in most settings, that double burden of malnutrition is really quite evident and rising, whether it's in rural settings or in urban settings. One of the things we looked at is what kind of diet is consumed. And by and large, it's really inadequate in quantity as well as in quality. So this slide is sort of the findings on inadequate consumption of fruits. Again, if you look at, regardless of the community in the sub-Saharan setting where we are based, there is less than once per day consumption of fruits across ages and across girls and boys. And similarly, as for fruits, vegetables are sort of low in consumption. On the contrary, you see that there is higher consumption of soft drinks, sweets, sugar-sweetened beverages, which contribute to the increasing occurrence incidence of overweight and obesity in those settings. And if one wonders if it is not fruits and vegetables, then it's really poor quality food such as soda. What else is being consumed? A lot of it is carbohydrate-based foods, grains, limited in vegetables. And if one looks at sort of what is offered by vendors in those settings, it's also unhealthy in the context of schools. This is our second study, which was done in the context of schools among younger adolescents. There are vendors within school and vendors around schools. And in both instances, a lot of sort of processed foods that tends to be high carb, high sugar, and limited consumption of fresh fruits and animal products that would be conducive to healthy nutrition. Another aspect that we looked at in the context of schools is the school environment. And as you can see on this slide, there are a number of challenges. In many instances, look at piped water or hand washing stations or toilets. The percent might be higher. Ideally, it should be universal, but it is still of limited quality. If one thinks about toilets by gender or changing rooms for girls, that is particularly challenging. In many instances, girls tend to be absent from school during their monthly periods because of the limited access to sanitary pads or a healthy or safe environment for them to be at school during those times, which obviously impacts their own educational achievements. Other challenges with sort of access to school clinics or school guidelines for health or playgrounds for physical activity. It might be a yes at 65%, but the size and the facility itself is suboptimal given the size of the school. So with that in mind, really, one of the elements to think through is what to do. I mean, we spend a lot of time thinking about what is the state of adolescent health and nutrition. And by far, there is a lot of anemia, there is a lot of undernutrition, a lot of overweight, and a lot of risk factors that contribute to that. And so in thinking about what to do, we have sort of been engaged in a series of intervention studies. I won't be able to go over all of them. I'll really highlight the first two. But there are other projects that at another time, if there is an opportunity, I'd be glad to share and contribute offline or at another seminar. But just a brief on each of the first two. The mega trial was a study that school-based, again, tapping into the institution of the school to provide an integrated approach to address malnutrition, which is really a challenge in many settings. This is Dodoma, Tanzania, which is the capital of Tanzania. The commercial capital is Dar es Salaam. The actual capital is Dodoma. But a setting where there is a lot of food insecurity, prolonged droughts, and water shortages. And so in that setting, a high prevalence of undernutrition at large. And our approach was to examine potential contribution of an integrated approach to resolving that. It's a proof of principle, 6 studies, rather 6 schools. 2 schools received standard of care, essentially no intervention from us, but received the usual services that the school offered around nutrition education and such. 2 schools received a full package of the 4 interventions, which I will mention briefly. And 2 schools received only 3 of them, everything except the school meals. So the 4 components are of the intervention in the full complete setting is a midday meal, essentially using traditional staples, fruits and vegetables, beans, high source of protein, some carbohydrates, ugali, stiff porridge, as some of you would recognize in the Tanzanian setting. A school garden that essentially provides a platform for education of adolescents around the value of nutrition and some physical activity. And perhaps some of that produce is available for the midday meal that is available in that school. It engages with focal teachers and brings in an agriculture extension worker to enable that process to happen with support of the focal teachers. Typically is a club outside extracurricular, early morning or after school activity. A third component around nutrition education, using the school gardens as a hub, but also enhancing the curriculum itself with sort of sessions, curriculum that is a little bit more fun than a rote sort of presentation of facts with some quizzes and such. And finally, an element that engages with parents and community members to use the school garden as a platform for enhancing parents' capacity to sort of learn and take some of these skills back home where they can engage with their own plot of land, usually around their house, and hopefully enable increased capacity at the household level. Some of the findings among adolescents themselves, this is the partial intervention and the full intervention overall, an improved in diet quality, by the Global Diet Quality Score, essentially a scoring system that measures diet quality, an enhancement in weight and in BMI for HC scores, and no impact on hemoglobin. The intervention was for 7 months, not long enough to have really a sizable and sustained impact. Similarly, for parents, either by attending the workshops that they would attend or by some diffusion from adolescents taking some messages home, there was an enhancement of their own diet quality as parents, as well as a reduction, sort of a relative risk or odds ratio of reduction in household hunger and improvement in home gardening in some cases. Overall, promising findings, but still much more needs to be done beyond this proof of principle with a more sustained and more sort of a longer impact. And that's something we are about to engage with. If I could move on to the second study. So this was essentially an integrated approach of diet through education, through gardening, through provision of food. This second study, SAMIA, as we call it, it's an acronym. We have wonderful team members who come up with fun acronyms, not me. Essentially looking at the role of micronutrient supplements, essentially a targeted intervention that addresses particular deficiencies, in this case, 3 arms. The study was carried out in Tanzania and in Burkina Faso. In each country, it was individually powered. In each country, there were 3 arms of 14 schools each. The 3 arms were control, or a weekly iron folic acid, or a daily multiple micronutrient supplements. These are in the context of schools. One looks at the composition of the supplement. It is IFA, which is typically used and available in settings, particularly for pregnant women. It's just extending that concept to adolescents. And multiple micronutrient supplements, again, multiples of the multiple nutrients beyond these 2, since in many settings there is multiple deficiencies that needs to be combated with multiple supplements. Just some of the findings in Burkina Faso. If you look overall, about 32% of the adolescents were anemic. 17% of them are moderate to severe anemia, a higher prevalence among boys, rather higher prevalence among girls compared to boys, balanced across the 3 arms more or less. And in Tanzania, an even higher burden of anemia of about more than 50%. Again, if you look at moderate to severe anemia, 26% in girls and 17% in boys. So a higher prevalence of anemia in that setting. If one looks at the impact of the supplements, it's a busy slide. I won't sort of go into all details, but 3 outcomes: anemia, moderate to severe anemia, or hemoglobin. In Burkina Faso, IFA had a modest improvement in hemoglobin. You look at the adjusted effect size. If you look at moderate to severe anemia, both of them not significant statistically, but in terms of magnitude and apparently stronger impact of MMS compared to IFA. And when you examine the same results in Tanzania, a more promising and clearer set of findings where same presentation, about a 40% reduction in moderate to severe anemia, but practically no impact of the weekly IFA given. Overall, promising findings, much more analysis were done that time does not allow. Happy to engage in the Q&A if there is time. But in looking at effect modification, so to speak, the impact was stronger among boys compared to girls. The supplements seemingly are clearly more effective in Tanzania compared to Burkina Faso. Some of the challenges in Burkina might be context specific, higher burden of malaria, higher burden of helminthic infections that weren't factored in really. In our study, although they are part of standard of care, even the control group theoretically should have received them, but we do not have that particularly assessed. So where do we go from here? The last few minutes, I'll try to share some of our thoughts. Clearly, both of them point to the value of both integrated nutrition, diet, education interventions, as well as targeted supplementation. So one seemingly relevant observation is that putting these two together seems plausible and reasonable, and that's an approach we are keen to advance as we engage with the next set of studies and with policymakers. And looking at integrating nutrition with other domains, really, it's a whole other sort of presentation, but briefly to say, one consideration that we are pursuing, not only for adolescents, but in general for women of reproductive age, is the potential to engage both nutrition sector and sort of family planning as a combined approach, rather a siloed set of approaches that typically are done. We have done a set of systematic reviews of the evidence that show that family planning is associated with a reduced risk of anemia, and that better nutritional status in turn has better outcomes in terms of fertility and pregnancy outcomes. So a logical approach programmatically, as well as from a provider's and beneficiaries' perspective, is to integrate these rather than have them being siloed. So that's something we would like to pursue. Other approaches that are important to consider is more systematic reviews of the evidence where there is data. So instead of just reviewing papers, we would love to pursue more IPD, individual participant data, to the extent that some questions warrant that, and there are adequate studies out there to enable that. Continue to do longitudinal studies to assess particular questions around anemia. It's not only nutritional. In many instances, there are multiple etiologies. So understanding that to be able to design the optimal intervention for anemia, which is a big problem in many of these settings. And engaging with trials and intervention studies that think about multiple domains beyond just nutrition, and multiple outcomes beyond just nutrition. You look at cognitive, school performance, and other outcomes. This is one study that we are advancing and completing, really, to look at human-centered design that engages with adolescents and other stakeholders to come up with approaches that consider the double burden of malnutrition in those settings, and arrive at what interventions could be done at the level of the school as a whole, at the level of individual groups of students, such as clubs, and then at the level of individuals where there might be particular needs to address in those settings. That's sort of a prelude to hopefully a larger effort using that prototype of intervention on a larger scale in many more schools that would be possible. My last slide to say that there are a lot of needs, a lot of progress, but a lot more needs to be done to advance data, to assess what is the state of health and how it changes over time, to introduce innovative and multi-domain interventions and look at their effectiveness and cost effectiveness, to really package that with capacity building so that the next generation of leaders in our settings, at Harvard and in our partner institutions are able to take the lead in the future, and to do that really as a partnership with all stakeholders, parents, teachers, policymakers, and academic members of the community. And with that, I would like to thank many partners who have been central to our efforts, and donors and universities and ministries, and open to any discussion. Thank you so much.
Thank you so much. What a tour de force. I know we ask you to kind of summarize a lot of information very quickly, but that was just masterfully done. And I feel like it's so striking to be presented with the data on that, especially, you know, the undernutrition and that anemia and the, you know, the human potential that is lost by that kind of gap in anemia is so striking. We have a number of questions coming in, so I'm going to try to put some of them in buckets. So I'll start with some methods questions. One of our participants is interested in knowing how you think about seasonality as you're measuring access to fruits and vegetables, since they vary with season. And another participant is asking about finger pricks as an accurate measurement of hemoglobin, saying that WHO and UNICEF recommends venous blood samples. And how do you feel about HemoQ as that, and how you think about that? So let's start with those two things, measuring fruit access and vegetables, and the HemoQ.
Yeah, thank you so much. Both are excellent questions. So seasonality is important both from the assessment as well as from the intervention approach. Ideally, we would assess in both seasons, high sort of lean season and sort of hunger season. At times when we assess with dietary instruments, we might ask about, say, in the context of a food frequency questionnaire, we ask about the last 1 month, and we ask when it's in season, what is the availability and consumption of certain fruits and vegetables, and so get at it that way. So it's important to be cognizant of that. In terms of interventions, it's also important to think about that in general, not only for adolescents, really, how to, when there is production, how to save some of that, and there are strategies to enhance sort of preservation of fruits, whether it's by drying or other approaches. But it's a very good question that needs to be thought through in design as well as in evaluation of studies. Obviously, when there are two arms, so to speak, that's critical to safeguard against sort of an evaluation where the intervention is done in one season and its assessment in another season. On finger prick, it's true, there are challenges. Increasingly, some evidence point that it might not be ideal. It is challenging to do full blood picture. It's costly. Again, in the context of trials, it's easy to do because both arms are subjected to the same misclassification of a finger prick. But where it is possible to do finger prick, it's good. Until that becomes more universally available, HemoQ gives a sense, and even if one discounts a little bit the burden, given that it might be higher or lower, it depends really on the quality of the droplet, so to speak. It is still a good measure to track where anemia is in those settings.
Yeah, especially when you're having pretty large sample size on multiple countries. Okay, thanks for that. Let me ask you a question about policy and integration. I think that's so critical, you know, and as you mentioned, many of the different aspects of the delivery of health promotion and prevention and care services are siloed. And even with the evidence you already have through your research and systematic reviews, how do you think the appetite is from policymakers to allocate resources into food as medicine, food as human potential? Like, where do you see that, or maybe how has that even evolved over your time in this space?
I think it's an important point, really, and part of it, in the case of adolescents, the siloing happens also by sector, really. So adolescents in the context of schools, when we think about nutrition and health services, that's really Ministry of Health, They are in Ministry of Education domain. So bringing those two elements together is critical. And there is openness to engage. And so it takes some sort of effort, frankly, led by our partners on the ground who are very keen and excellent at navigating that in every setting. Part of it also is translating some of the findings in a way that are easily digestible. It's harder for busy policymakers to read papers. And so one of the efforts that we have pursued is to kind of move to a place where we develop policy briefs from some of our research, and that makes the findings more accessible. Engaging with policymakers as the research is being designed so that they are on board. And be able to sort of see the findings at the end and be part of the ownership of the findings and thinking as they plan their next budget, rather than sort of see them at the end and sort of hand them some findings when they haven't been as much involved.
Thank you. I'm gonna ask my last question as a follow-up to that, because I think that I often get the question from trainees and new investigators about how to make that policy connection. And so, you're Professor Wafaie Fawzi and, world-renowned for your work in this area. So I imagine having a conversation with the policymaker is one aspect for you and your team. How do you advise your trainees or mentees or others on making that connection with policy early, or when they're thinking about their designs, maybe if they're more junior or just getting started?
Yeah, I think we have wonderful trainees, as you know, here and at our partner institutions in Africa. And a lot of it is our responsibility as faculty to enable that linkage, provide the platform, and they have excellent ideas they are able to advance. So really promoting experiential learning for us as a university and academia in general is important. We have the connections, our partners have the connections, and enabling that sort of platform for trainees to come on board and learn from the process through J-term experiences, summer school, summer experiences. That's really important. So it's a call for us to continue to do that and for us to sort of invest in that as academic institutions.
Okay, that's great. Thanks. So believe it or not, we're almost out of time already. It went by quickly for me, but I'll give you the last closing thoughts in our last minute or so, Professor Fawzi.
Great. Yeah, thank you so much, Louise. It's a great opportunity, and thanks to the audience who has been here. I think one key point that I would leave us with is, the Harvard Global Health Institute is amazing. It's a bringing together of global health at the university, as I said at the outset. But that also provides us really with an exciting opportunity to bring these various disciplines. And global health is a multidisciplinary team. We benefit a lot from engagement across hospitals, across partners at the Kennedy School, at the medical school, at the School of Public Health, business school, and beyond. And so really harnessing those various disciplines and research approaches is a great way to advance the field, and we can learn a lot from one another. So thank you so much for all the work that happens at the Institute, and excited about the years ahead.
Thank you so much. And I think the issue of food security and undernutrition and, obesity and school gardens and education, and bring those together, is a really good example of the interdisciplinary nature of trying to advance health. So thank you for joining us today. Thanks to all of our audience members. I'll just remind everyone the session was recorded, and so we'll post it on our website in the coming days. Thanks to everybody. Thanks, Professor Fawzi, and have a great day to everybody.
Thanks so much. Thanks, everybody.